evening to you and welcome to this month's Rural Doctors broadcast. I'm Gerry Gannon. Thanks for your company. Tonight we focus on obstetrics. We'll be talking to the head of obstetrics at King Edward Memorial Hospital, Dr Anne Karczub, as well as obstetricians, GPs and midwives from Kalgoorlie, Dunsborough and Peel. But before we begin, a reminder to you about our upcoming Rural Health West annual conference. This year the theme is Don't Panic, It's Only an Emergency. And as always, the conference will be a great opportunity for you to get together with each other and with leading health professionals from around the country. It'll take place on the 4th and 5th of April at Burswood Convention Centre, and the lineup this year provides plenty of hands-on workshops as well as incisive presentations from doctors who are both experts in their field and skilled presenters. So if you haven't received a registration form yet or need further information, please call Rural Health West on 08 6389 4500. Now, pregnancy and childbirth can be a time of great joy, but for some it can also hold a lot of fear. Despite everything we have available to us in this day and age, there are still risks associated with childbirth. Because of this, obstetrics can be both a highly rewarding area and a particularly daunting area of practice, especially in rural areas where the level of support and fallback services can be limited. With this in mind, Rural Health West endeavours to provide support for those who wish to train or begin practice in obstetrics in rural and regional areas. We thought we'd start tonight's broadcast by talking to some of the people involved in our support programs. We spoke to Dr Kylie Sterry, who is currently engaged in advanced obstetrics training in Kalgoorlie, and to Doctors Annie Marshall and Sarah Davies, who've both recently begun to practice obstetrics in Dunsborough under the mentorship of experienced GP obstetrician Dr Mostyn Hamdorf.
I always intended to be a country doctor, and the idea of relocating my family, knowing that after the 6 months in Perth we'd only have to relocate again, put me off the idea of doing it. And if I had to do it, I would have actually not bothered doing the extra training at all, rather than disrupt my family. So between Rural Health West and Barney McCallum, myself and Kalgoorlie Regional Hospital, we set up the obstetrics training, the advanced obstetric trainings here. We got approval from the Joint College of Obstetricians and GP to get Kalgoorlie Regional approved as a training hospital. We got some additional funding from Rural Health West for me to do some more training in Perth, funded, and also to fund Dr McCallum to make up for the teaching time that he gives up to teach me. I couldn't think of a better way of doing my advanced training than what I've got here. I think I've seen better variety of obstetric cases here. I've had a lot more hands-on experience than I think I would have gotten in a major teaching hospital with several other, junior staff competing for the same kind of work. I think I've got brilliant one-on-one teaching from the one consistent person, which I went to King Edward recently, did some training there, and the consultants commented on my surgical technique was impressive for how the length of training I'd done. And I think it was because I had the consistent teacher. And Dr McCallum has been able to see how my training's going and been able to fine-tune, well, okay, you're doing really well in this area, but this area needs work. Whereas if you had a different consultant all the time, you would get people wouldn't pick up on where your deficiencies are nearly as well as one consultant. Dr McCallum, prior to me coming, didn't have a regular assistant for his theatre lists, so he would have either extra nursing staff or he'd have a junior surgical intern or resident or a medical student to assist him with his theatre cases, which was working fine. But because I'm a regular member of his surgical team now, basically, I've come to know his operations, and that actually makes us quite an efficient team. I also get to know the patients on the ward rounds, so I'm able to add added information. People often tell me more information than they might tell Dr McCallum, and I can add that to the care. I think there are plenty of units in WA in particular who could easily support having a trainee and have the added advantage that you train the person in obstetrics, they hang around, and they then are that extra person in the unit that you need. And if they've trained in the bush, they're more likely to want to train more people in the bush and show that it can work. And it has. I mean, my situation has proven that it works incredibly well. to train people in the bush and keep them here.
I did my basic hospital training and then went to King Edward in Perth and did my Transcog diploma at the end of 2006. So there was quite a big gap between when I had my hands-on diploma time at the hospital in the city to when I came to the country and was able to be in a situation where I would use those skills. So it was pretty daunting.
I was in Darwin in 2006 and I did 3 months of hospital obstetrics up there, which I really enjoyed, and it kind of came naturally to me. It was something that I felt comfortable with, and I sort of gained confidence quite quickly and really enjoyed the whole idea of looking after a mum and a baby. And I also attended the, I think it was the Rural Clinical School Conference, and Anita Moss and Viv Duggan actually presented their paper about the pilot of the Rural Health West Mentor Program.
The mentoring program as established by Rural Health West was to provide support for GP obstetricians to enable them to encourage younger GP obstetricians to areas whereby they can provide practical and mentoring support for GP obstetricians hoping to enter into the rural workforce. The mentoring program enables us to provide physical support by compensating us for our time, for teaching, and also to provide backup for the young GP obstetricians while they're attending to deliveries at our local hospital.
Mostyn was my GP supervisor anyway for my GP training, so it was the perfect transition. He agreed to do the mentoring for the obstetrics, and I was kind of babied back in, which was very reassuring, because it was something that I was quite worried about.
Well, there's certainly nothing more rewarding than going through the pre-counselling, preconception counselling, antenatal care, and then delivery, and then the postnatal care. That can be a highly rewarding experience. It can also be, as you point out, very daunting. There's nothing more lonely than attending to a difficult delivery at 3 o'clock on a Saturday morning when there's very little backup.
It is a very lonely profession when you're on your own, and having a team that you can bounce ideas off and who will back you up is just so valuable. Gone are the days where you do all your 6-month diploma and you do 200 deliveries and 50 vacuums and be able to go and work in rural obstetrics, all skilled up. The diploma these days, you have to get 25 normal vaginal deliveries and 5 vacuum deliveries, which is hardly sufficient to then go and independently practice rural GP obstetrics in the country.
That's where this mentoring program comes into its own, in enabling us to free ourselves up to provide that ongoing backup for the more recent diplomats.
We actually are able to bill the hospital for the delivery, and the supervisor will then get a payment from Rural Health West for each delivery that they come and assist us with. So I guess that means that we can feel very relaxed about calling someone in to help us, knowing that we will still get paid for the time that we've spent, looking after this woman in labour, and also our supervisor will get paid for the time that they've spent coming in to assist us. So that takes a huge amount of stress and anxiety out of the whole equation, because you know that everyone's going to get remunerated appropriately.
Whether or not you needed to use the help was not really the issue, because most babies deliver themselves really, and we don't actually always have to do much. But for simply knowing that there was that backup was what made it something that was more appealing to me to get involved in, and less stressful and more rewarding, because instead of worrying about what happens if this gets beyond my skill set, it's like, well, that's fine, I'll take it to there, and then I've always got that backup.
We find as the diplomat gains more and more experience, then the number of times that they're required to ring us or for our physical presences tapers off. And so it's a bit like casting off those trainer wheels almost.
Did a delivery last night, and as driving home, I was remembering the first time I was on call and the first time I got called from the hospital. I remember ringing Mostyn saying, what if she has a shoulder dystocia? What if she has a PPH? And to the point where that stuff wasn't kind of on my mind yesterday. I just remember coming home, it was just went through the motions, the baby's fine, and I think that I noticed that there had been a transition, but I wouldn't say it happened overnight. It was a gradual process.
And we've actually, as older GP obstetricians, have to justify every action that we make, and that it makes you double think everything that you do and keeps you on your toes. And so in that regard, it's been highly beneficial for us, for the older GP obstetricians as well.
Having been able to establish a rural obstetric practice would determine whether I would stay here, definitely. And I don't know that I would have re-engaged my obstetric interest if it wasn't for having that mentoring scheme, because I wouldn't have felt safe.
It's been beneficial for us, it's been beneficial for the incoming GP obstetricians, and it's beneficial for the patients.
Some win-win situations there, it seems. Now, if you'd like more information about support for training or practice in obstetrics, you can contact Viv Duggan through the Rural Health West reception on 08 6389 4500. Now, while we were in Kalgoorlie, we were hoping to put some of your questions to Dr. Barney McCallum, but due to the nature of obstetrics, he was otherwise engaged. We were lucky enough, however, to get some time with Dr. Anne Karczub from King Edward Memorial Hospital. Dr. David Jameson asked her to respond to your questions and some of his own.
Thank you, Anne, for joining us. Perhaps I'd like to start off with some of the routine antenatal blood screening tests that you'd like to see on patients.
I think sometimes people get a little bit confused. How detailed should my antenatal testing be? I always remember it, in a couple of ways. Firstly, I think, okay, what are the components of the blood that I want to know about? I want to know a full blood count, I want to know a blood group, and I want to know an antibody screen.
Yep.
Okay. Then I think, what are the infections I want to know about, or immunity to infections? And then I think old and new, the ones we've known about for a long time and the ones we're looking for more recently. The old ones, of course, are syphilis and rubella. So does the patient have a syphilis infection? So we do syphilis serology, and then we do rubella immunity. And then looking at the new infections. And now we say HIV, Hep B, Hep C should be offered to all pregnant women.
If you felt they were in a very low risk group, would you...
You would still offer them,
yes. Would you insist?
I think we would say, we screen you for syphilis serology. Mm-hmm. The chances of syphilis serology in low-risk women are very low risk, but it's a treatable disease and it's important to know. And we know that we do turn it up occasionally. And similarly, HIV, Hep B, Hep C will be in women who may have no idea that they were at risk. Particularly HIV, even though it's obviously very uncommon in a low-risk group, it's absolutely vital that it should be known about, because we can change quite dramatically the outlook for mother and baby. So it's something that should be offered to all pregnant women.
Yeah, perhaps prenatally, chickenpox or varicella, would you?
Chickenpox is one that's not yet recommended as a universal test we should do, but I think it's quite sensible. If someone's got no clear indication that they've had chickenpox, that you should test their their varicella immunity, because we can offer them immunisation. And of course, it takes away a lot of anxiety for a woman to know that she's immune to varicella, particularly as it's still around in the community. So I think that that's probably a reasonable test to do, although it's not yet recommended as routine.
Perhaps toxoplasmosis?
Toxoplasmosis and cytomegalovirus always rear their head, and parvovirus being the other one. Mm-hmm. They're not recommended as routine antenatal testing. Cytomegalovirus is not helpful to know if you've got IgG antibodies, because it doesn't necessarily confer immunity, and you can be reinfected with cytomegalovirus. Yes, if you're immune to parvovirus, you're immune to parvovirus, and 50% of people are. 50% of people are immune to toxoplasmosis as well. But again, unless someone was in an occupation where they were particularly concerned about those two issues, and perhaps someone who works in a childcare centre, maybe parvovirus, but it's certainly, again, not something that's routinely advocated. And don't do cytomegalovirus testing, because that will just get you into trouble.
Sounds good. Pap smears in the first trimester, perfectly reasonable to do.
Perfectly reasonable to do. I think if you've got someone who's never had a pap smear, or it's been a considerable time, over 2 years, it's an opportunistic moment to get the pap smear. Two things. Firstly, that sometimes you may not get into cervical cells because people, I think, are a little bit reluctant to scratch too enthusiastically in the endocervical canal, and also I think probably there's not as much shedding, but not to be too anxious about that. You're just really wanting to sample the squamocolumnar junction, which is going to be on the ectocervix. Secondly, to warn women that it's possible they'll get some bleeding, so to do that beforehand, and that this is not going to cause a miscarriage. You have to be very, very clear with the woman.
So being upfront.
Being upfront and saying, look, you may get some bleeding because the cervix is vascular. Don't be alarmed if that happens. And this will not cause miscarriage. You may have a miscarriage because this is the first trimester, but it will not be caused by this pap smear.
Sure. And doing a PCR test for a chlamydia at the same time would be
There's now a statewide directive that says that all pregnant women, not just women in a high-risk group, should be offered chlamydia screening in the first trimester. So if you were doing a pap smear, it would make sense to do a PCR for chlamydia and combine that with a first pass urine. But for women who you're not going to do a speculum examination on in that first trimester, just offering them a self-administered low vaginal swab and the first pass urine is sufficient.
So you do both tests?
You do both, yeah. In a symptomatic woman, obviously, then you need to do the speculum and you do the swabs, because obviously the gold standard is the PCR from the endocervix, and combine that with the urine, either a urethral swab or a first pass urine. I guess the idea is not too invasive, and the purpose of screening is to have an acceptable test, which is the self-administered low vaginal swab and the first pass urine. There is a directive that's out, as I say, from the Health Department about this, about repeating in higher risk groups and women from particular endemic areas to combine that first trimester with a gonorrhea, a screen for gonorrhea, and then in those high risk groups or from endemic areas to repeat syphilis serology at 28 weeks and repeat gonorrhea and chlamydia at 36.
Which brings us to that 28-week check. Would there be any other tests you'd want to do at that 28 weeks?
The usual antenatal check at 28 weeks, the blood pressure, measuring fundal height, which I think starts to become useful at that time. We're offering women screening for diabetes, and so if they're in a low risk group or a medium risk group, we'd start with the oral glucose challenge test, which is the 50-gram load. You don't have to fast, and you have your blood test an hour later. And if they're rhesus negative, it's the time to do an antibody screen just prior to giving them, or at least offering them, prophylactic anti-D. And for those women in the endemic areas, it will be time to repeat their HIV serology and their syphilis serology.
I'd just like to spend a bit of time now about Down syndrome screening and some of the problems that our country doctors have trying to organise those tests. Briefly, could you tell us the difference between the first trimester screen and the second trimester screen?
The first trimester screen is a combined screen. It's a combination of doing nuchal translucency, which is a measure of the thickness of the baby's neck, and a blood test. Blood test basically looking for two proteins, beta-HCG and protein of pregnancy. So therefore you're relying on having a skilled ultrasonographer or ultrasonologist giving you a nuchal translucency measurement, and then you're combining it with a blood test to give the woman a risk. And she gets a risk for 3 trisomies, trisomy 21, 18 and 13 as a screening test. The maternal serum screening test, which is done between 15 to 17 weeks, is a purely biochemical test, and it was known as the triple test because it looked at 3 things, which was estriol, beta-HCG and alpha-fetoprotein. And what that does is give you a risk of having a baby with trisomy 21, and it also gives you a risk of having a baby with spina bifida. So it actually tests for slightly different things to the first trimester screen. Obviously, the first trimester screen, you get your risk back in the first trimester, whereas the maternal serum screening test or the triple test, you're getting a later result.
There is a particular problem though, isn't it? It's not just quite as straightforward ultrasound as perhaps doing a knee or a...
Really to be able to give or to offer that test, you need to have an ultrasound facility that's been credentialed to do nuchal translucency screening, and that is a credentialed service. The ultrasound service has to submit 50 cases, and that has to be peer reviewed, and they need to be credentialed because obviously it's operator dependent. So if you're going to rely on that test and it's going to be a good quality test, that needs to be in place. So not all smaller places may have someone who is credentialed to do that sort of screening. And so for the individual GP, they need to find out what's available in their particular area. I know in some places they might have people who would do that, who would visit and do that at a particular time. In other instances, if the woman wishes to avail herself of that test, she may need to go elsewhere. Alternatively, she may be offered the option of the triple test, which is still a good test for risk screening for trisomy 21.
The first trimester screen is now covered by Medicare rebate.
I understand it is, yes.
And I understand that certain hospitals will also allow patients to travel on the patient's assisted travel scheme
to have that
to
done.
Travel to Perth if they haven't got that in their local area.
Yep, and of course the trick is you want to do it at the right time. The ideal time to do the blood test is, they say, 10 weeks, and then the ultrasound is somewhere between 11 and 13 plus 6. So you need to have good dating, which is why the issue has arisen about the 2 scans in the first trimester, because often the woman will have a dating scan to ensure that, if she's got very good dates, then you might take the risk, I suppose, or the chance that you have got it correctly. But there's always the possibility that you may need to do a dating scan.
And you'd offer that test, you'd recommend that that test is offered to all women?
I think it needs to be offered, but I think it's really important that you have to have good counselling with it, because there are a significant proportion of women, probably less than half, but I would hazard a guess somewhere between 10 and 30% who don't want the test. And it shouldn't be offered as, this is one of the tests we will do. It has to be explained to the woman what the test is. Also, that it is a screening test. So if she falls into what I deliberately call the higher risk group rather than the high risk group, the chances are actually that there's nothing wrong with her baby. It's just that she's in a higher risk group than the other group of women who are in the low risk group. And of course, you have to sort of explain to those women that this test does not mean they absolutely have a baby without the condition of trisomy. So it makes the first booking visit quite an intense visit sometimes, and if you're doing the counselling properly. And then you have to explain to women in terms that they comprehend, and that varies from person to person, that this is a screening test and what that means. And I think you do have to mention that if they fall into the higher risk group, would they want a diagnostic test? And the diagnostic test, of course, is invasive. They're looking at amniocentesis at 15 weeks, or they're looking at chorion villus sampling, which is the test that can be done more immediately. Now, because the risk of miscarriage with chorion villus sampling is higher than amniocentesis, it tends to be reserved for that group of women who have quite a high individual risk. And so you need to touch on the fact that the first trimester screen is great if it's normal and they're low risk, that's reassuring, but they should have thought through what they might do or want to do if it is that they fall into the higher risk group. And because at that point some women may choose not to have the test, and that's important. The real disaster is if you've sort of presented this test as, it's just one of the tests we do, the woman comes back as being in the higher risk group, and suddenly you're faced with explaining these choices which she doesn't want necessarily, then all you've done is generate anxiety.
She stops at the point where she doesn't want the amnio.
Yes.
And then worries the rest of the pregnancy that she's going to have a normal baby.
Or indeed she feels compelled to have the amnio when she didn't really want to have it, but she's so anxious that she feels she needs to go ahead.
Some good information there, and we'll come back to that discussion with Dr. Karczub later in the programme. Now, bleeding during pregnancy can be quite common, and it can understandably be the cause of a lot of anxiety for an expectant mother. While we were in Kalgoorlie, we spoke to GP obstetrician Dr. Anne Karczub about how to approach a presentation of bleeding during pregnancy to, first and foremost, get the best clinical result, but also to try to give the mother some certainty or reassurance as quickly as possible.
So light bleeding would be 1 or 2 pads a day, heavy would be something like 6.
Bleeding in early pregnancy is a relatively common condition that most GPs will see if they practice in family medicine, whether they do obstetrics or not. A lot of cases of bleeding will be benign. However, it must be proven it must be considered to be abnormal until proven otherwise. And there's some important serious causes of bleeding that need to be excluded before you can reassure yourself and the patient. Probably the first one is to establish whether they are in fact pregnant, or do you have some sort of evidence that they are pregnant. And you need to know their last menstrual period if they are able to tell you that, which will give you an estimation of how far they think they are pregnant. You'll want to know if this is something that's happened before, either within this pregnancy or in a previous pregnancy. You'll be very interested in the patient's previous medical history, whether they have any other causes that might predispose them to bleeding, any medical problems or any gynecological or other obstetric problems. And then you need to get down to specific issues related to this pregnancy. So you want to know, is the bleeding heavy, is it light, have there been clots, has there been a pain associated with it, is there other symptoms? And all of these things are important in trying to reach a diagnosis and guide your management. For an argument's sake, let's say that you have a mother comes in and she has heavy bleeding, she has abdominal pain, and she looks pale, she has a racing heart rate, and you're concerned she has an ectopic. Clearly this is something that needs to be managed as an emergency. In the GP rooms, you will need to organise transfer to your nearest hospital, and the wisest thing would be to actually have her transferred with an ambulance, but that's a clinical call depending on the degree of compromise you think your patient's in. But someone in that situation is going to need IV resuscitation and fluids, they're going to need blood cross-matched, and they're going to need urgent surgical or obstetric review with a likelihood that they're going to go to theatre.
But we need to make sure whether it's not serious or serious, and we can't do that until we've done the examination and checked with the test, with the ultrasound and the blood test.
Once you've established whether that you need to act immediately, if you need some resuscitation, or whether you've got time, which is usually the case, it's a matter of organising those tests. The issue here is trying to establish where the pregnancy is, how far pregnant the woman is the pregnancy viable, and then are there any specific issues that need to be related to the bleeding in this particular pregnancy. So blood tests are useful. Blood tests are useful because they tell you whether the pregnancy is actually occurring, and particularly a quantitative beta-HCG will give you some estimation of where you think the pregnancy is in the time frame. A blood picture is useful because that will tell you if the bleeding has been significant and whether there's any significant loss of red blood cells. We're very interested in the blood group of the mother because there are some blood groups, such as rhesus negative blood types, which potentially can become a problem later, either in this pregnancy or in subsequent pregnancies, with isoimmunisation from the baby. And so there's management issues there. And so with a blood test, if you do a full blood picture, quantitative beta-HCG and a blood group and antibodies, that would be a very good starting point for all bleeding in early pregnancy. The next most important test would be to do an ultrasound. Now, if the doctor has ultrasound skills, and many GPs and GP obstetricians are now obtaining these skills and have their own ultrasound machines, then they may well be able to establish that they have a viable pregnancy, that it's intrauterine, and that things are looking pretty good. However, if those resources are not available, then the doctor should access that test in as early as possible time frame for the patient. And that's regardless of geographically where they are. If they're in a remote area, then that patient should travel to an ultrasound service. If there's an ultrasound service in their site or their town, then they need to access that. And the importance of ultrasound is several issues. Firstly, it can tell you whether there's an ectopic or not, and we probably can't emphasise this enough. If you haven't established that there's not an ectopic pregnancy, then there's potentially a problem for this woman. If the pregnancy is intrauterine, which is where it should be, then you'll want to know some estimation of how pregnant she is. So what's the size of the fetus, which will give you a relatively accurate estimation of the gestation. And that's important as well because it allows planning for the pregnancy and also allows you to check whether the pregnancy is proceeding at the rate you would expect from your estimated gestation from the period date. And if there's a mismatch between those things, that might tell you something as well in terms of the likelihood of a threatened miscarriage. Once you've established there's an intrauterine pregnancy, you'll want to know whether that pregnancy is active or has a fetal heartbeat and looks like it's viable. And so those two things, heartbeat and fetal activity, are very reassuring signs. The absence of those is not reassuring, and that would suggest that this pregnancy is either likely to miscarry or is in the process of miscarrying.
The only other thing that is really important that we need to establish is that it's not an ectopic pregnancy. That's a pregnancy that's not in the uterus, and that's outside.
So there are a number of causes of bleeding that make us get a little more excited, and clearly number one of these is an ectopic pregnancy. As the fetus reaches a certain size, and typically this is probably from about 8 weeks on, there's a high risk if that's not treated that she may have life-threatening bleeding, and it's the ectopics that's missed and then bleeds and then presents late is the one that we worry about. If you haven't proven that there's not an ectopic, then you haven't proven that there isn't a problem. If the pregnancy is very early, you may not see a fetus early on, and so you need to repeat the test and repeat the blood tests, repeat the quantitative BHCG and see that that's rising until you're confident that you've got a pregnancy in the right place. If you've done those tests and you've found out that the woman is pregnant, that the dates of the pregnancy match what you expect, that the fetus is in the uterus, that there's a heartbeat and it's active, then you can to some extent be reassured that then from the pregnancy point of view that this is less of a risk to the mother and the pregnancy. You still haven't established the cause of the bleeding, and there may be some anxiety related to that, and there may be some other important issues that you need to investigate. There may be bleeding, nearby, if you like, in around the area that may not be related to pregnancy, but still be causing the symptoms. So, for example, we may have bleeding from the cervix. There may be a cervical polyp or some area of the cervix that's causing some bleeding, and even a small amount of bleeding can be very visibly apparent and cause some anxiety in the patient. There may be bleeding from infection, so infection, either a sexually transmitted infection or even a urinary tract infection where there's frank hematuria. That can be misinterpreted as vaginal bleeding, and both of those causes need to be investigated. Sometimes women can't be very specific about where the bleeding's from and just know that it's from that general area, and so bleeding from hemorrhoids may also cause be a reason for the presentation to your rooms. In some cases there will be no demonstrated cause, but what you have established is that there's no infection, there's no other visible cause, that you have a viable pregnancy, and if the bleeding settles, then you can reassure the mother that everything appears to be okay. The management in that case is expectant in that we watch them and we repeat the test, we repeat the ultrasound if we think things are developing, and we follow up the issues with the mother. In some cases that bleeding will settle and the pregnancy will carry on and become a viable pregnancy and continue through to term. We don't know which of those are going to be, but sometimes we can get indications from our early tests of whether more or less likely to miscarry. Some guides about the likelihood of miscarrying. The degree of bleeding is a good measure. So if there is a lot of bleeding, that's not a good sign. If there are clots, that indicates there's been bleeding and then pooling of the blood, and that's not a good sign. The level of fetal activity, so if a sluggish-looking fetus is not as reassuring. Pain that's associated with the bleeding, although it doesn't mean anything in itself, but pain and lots of bleeding, again, is not particularly encouraging and would indicate that pregnancy is more likely to miscarry.
Thanks to Dr. Andrew Kirk for his thoughts and advice. Now let's return to Dr. David Jameson and his discussion with Dr. Anne Karczub from King Eddie's.
Well, we've just been listening to Andrew Kirk talking about bleeding in early pregnancy. Perhaps you could just outline, when is it too early to use anti-D for someone who's been bleeding in early pregnancy?
The Australian guidelines say that it's never too early. If they're pregnant, they're Rh negative and they're bleeding, it's recommended that they be given a dose of anti-D.
However pregnant?
However pregnant. This differs from the UK, who would say that they wouldn't give anti-D usually before about 10 weeks unless there was a surgical evacuation of the uterus. And I know that there's some talk about people thinking, should we adopt those guidelines? But at the moment, what we're saying is any bleeding in early pregnancy, give anti-D.
And how long would one vial of anti-D last?
It's usually around about 4 weeks.
So if you had bleeding and then you get another small bleed a couple of weeks later, you'd still be safe with just the
yes, I mean in early pregnancy, yes. If you've got any queries, you can always ring up and have a chat to some of the people at Blood Bank. But the guidelines are pretty specific.
Another issue with bleeding in the early pregnancy is a lot of GPs will have handheld Dopplers in their rooms, and would it be reasonable to use that as a way of confirming fetal viability in early pregnancy?
It's reasonable if you put a Doppler on and you hear a fetal heart. I think that's reassuring. I think probably important to say you may not hear a fetal heart, and that's not necessarily a bad thing, just to make that clear. It may preempt sending someone, I guess, for an ultrasound, particularly if they have to travel a long distance. I know that sometimes at 18 weeks I can't find the fetal heart with the dop tone, so then it's there. So I think sometimes it's problematic, and you may often not hear anything.
But a hearing is a.
I think hearing. If you're hearing a fetal heart, you're hearing a fetal heart, and that's fine.
There's been some concern about the size of women are getting these days, and perhaps you could give us some guidance about what are the risks and when would it be reasonable to be seeking specialist advice? With
obese women, there's no doubt that the more obese a woman gets, the more at risk in some senses her pregnancy becomes. I mean, she's at risk for hypertension, gestational diabetes, preeclampsia. And indeed in labour itself, there is some evidence that these people don't labour as well. Certainly nulliparers are more inclined to have obstructed labour. They have more assisted deliveries. There's more chance they'll have a macrosomic baby, and actually birth difficulties, again, shoulder dystocia, postpartum hemorrhage, you name it. The stats are there. Mm-hmm. And of course that's not looking at things like anaesthetic difficulties, epidural difficulties simply moving the patient, the facilities that are available, the labour ward beds, the toilet seats, the theatre tables, all become difficult at the really morbid, obese levels. People say, why isn't there state guidelines about this? And it's because it's difficult to write guidelines for every case, and so rather what we've done is suggest that each maternity unit sits down and has a meeting with the people who are involved in maternity care, and that would be the obstetrician, the GP obstetrician, the anaesthetist, the GP anaesthetist if they have all of those people, the hospital manager, the midwifery manager, and say, look, what capacity do we have to deal with women? What BMI at booking would be automatically an exclusion criteria, and then perhaps another BMI at 34 weeks. So that there might be women who fall into this grey area where you think, well, by the end of pregnancy they may exceed what we're happy with. The worst case scenario is that there is a difference of opinion, that the woman is told by one person, no, you're fine to deliver here, and then she comes to the hospital, or she sees someone else, or she sees the anaesthetist and said, I'm not happy. So there has to be consensus. The worst case scenario is we've had women transferred to us who've actually had their induction started, and then someone's come along and said, we're not happy, or the hospital manager. You get an extremely distressed woman, usually a very angry obstetrician or anaesthetist. We've even had women transferred in labour who've practically delivered in the ambulance, and that's just a disaster all around. So to try and prevent that, I think units need to be very clear. BMIs over 40, you're getting into that sort of difficult zone.
So a bit of a red flag for the GP with a BMI of more than 40 should be really thinking about seeking some...
Yeah, and I think that GP should know and have had very clearly from their local maternity unit, what are they happy to deal with? And it behoves the unit to have that policy very clearly to the GP.
It'd be important to include the RFDS as part of your
yes, of course,
management of...
And your ambulance service as well.
Because there could well be issues with weights.
I mean, sometimes these women do need to be referred to King Edward. We're very happy to book the patient with us and then have the local hospital to continue the shared care, or the local GP to continue shared care, and have the patient around either at the time of delivery or a planned evacuation of the woman from perhaps a peripheral centre to be closer by around the time of anticipated time of delivery. So we're very flexible about that. And sometimes a phone discussion can be helpful to prevent women unnecessarily having to travel long distances, when really the issue may be actually just about the time of delivery, not about the antenatal care.
We might move on now to talk about preterm labour and the use of fibronectin as a possible test to work out who to try and send and who to try and keep.
I think it's a useful test. Is for those people who may not know, it's a protein which is sort of excreted by the fetal membranes. It is actually positive in the second trimester, so it's not a useful test up until about 20 weeks because it will be positive, but then it becomes negative. The use of fetal fibronectin is its negative predictive value. So if you've got someone who comes in preterm labour, or threatened preterm labour more correctly, you do a speculum examination. Again, it would not be useful to do fibronectin on someone whose cervix was dilating because you've got the diagnosis of preterm labour. But in someone who ostensibly the cervix is closed, but they are having uterine activity, it's useful to take a sample of fluid from the posterior fornix and do the test for fibronectin. If it's negative, it's reassuring to within about 98% that this woman's not going to deliver in the next 7 to 10 days. If it's positive, it's really not of great value. It's like tossing a coin, it's 50-50. I think for the GP or the obstetrician in a regional or rural country setting, it can be useful in that if it's negative, it gives reassurance that these contractions are unlikely to go on. Now, here at King Edward, we use it for whether we give celestone or nifedipine. So if we have a negative fibronectin, we would just give the woman morphine and try and sit it out. And we would look for more evidence that the labour was truly going on with the cervix opening, shortening, the contractions increasing in intensity. I think if you're in the country and you've got a negative fetal fibronectin and you're in that sort of 24 to 34 window, I think it's very reasonable. You can still give the woman nifedipine, you can still give a celestone, but it gives you perhaps the confidence to wait before you call the RFDS or the ambulance to say, this is probably going to settle down. You can give the woman analgesia as well. I think it's important people are aware of the limitations. For example, if there's been bleeding, if there's been intercourse within the last 24 hours, if there's been a vaginal examination in the last 24 hours, a positive fetal fibronectin then is not useful at all. You could still do the fetal fibronectin if someone has done a vaginal examination prior to you doing your speculum, because if it's negative it's still useful, but if it's positive it may be contaminated by manipulation of the cervix or blood or trauma.
Yeah. So a negative test is great.
A negative test is good. Positive test, yeah.
Now, you mentioned earlier that they're quite expensive tests, and that some of the more peripheral hospitals won't be using very many of them.
Yes.
And that
they can expire.
They can expire quite quickly, but that King Edward's would be happy to swap.
Do an exchange, yes. I think if you trade it with a unit that uses more samples, or you trade it with us and get a new one, because we would use them, several a day often, so we're never going to have a problem with ours sitting on the shelf too long.
So it's something worthwhile the GPs to talk to their units about. It's certainly
something to talk about. And the hospital administrator might say, my goodness, we're not getting this very expensive item. You can perhaps explain to them in the statewide context it's probably worth it.
Hypertension is a massive topic, and we won't have time to cover it all, but perhaps we could focus on some of the more acute issues for general practice in the country. What would be your guideline for commencing an antihypertensive in someone who's previously normotensive, first pregnancy, and what drug would you choose?
I think the way of looking at it is intrapartum and antenatally. I think, just to step back I think the first thing is if someone presents with hypertension is to say, is it real? So you have to make sure that it is. Secondly, was it a pre-existing hypertension? So for that you need a non-pregnant or first trimester blood pressure. If you think it's hypertension that's been caused by the pregnancy, the next question to ask is it preeclampsia or is it gestational hypertension? And preeclampsia is like the Rottweiler and gestational hypertension is like the Labrador. One's very nice and gentle and the other one is going to get you. The next question is that if you think that it's preeclampsia, ask yourself the question, why am I not inducing this patient if they're term? And if they're not term, I need to watch this patient extremely closely, or I may need to transfer this patient. So I think preeclampsia it's important to identify if you think you're dealing with it. To answer your question then about starting an antihypertensive, if they're preterm, I think it's good to control the hypertension. Methyl dopa, labetalol are good choices for ongoing treatment in the pregnant woman. In the sort of more acute instance, if you want to bring the blood pressure down and start them on something more chronic, I think nifedipine a great drug. It's oral, it works quickly, it has some side effects but usually nothing too terrible. If you want to use something intravenously, hydralazine is still the drug to use, but be cautious because it takes about 20 minutes to work even if you give it IV, and you can crash the blood pressure on hydralazine. So nifedipine's a pretty safe option even in the acute setting. So you want to bring down the blood pressure, and basically you want to bring down anything that's 160, 105 or above, and then you start them on an antihypertensive. But this does not change necessarily this underlying thing. They need delivery if they're term, or maybe they need to be transferred and I'm talking now preeclampsia. Because this is going to evolve and it's a nasty disease.
So tips for spotting the Rottweiler?
Tips for spotting the Rottweiler. Think clinically. The young woman, the first pregnancy, the woman who's had it before, I think are important. I will often say to medical students, you've got a woman who comes in and that she's 22, it's her first pregnancy, her blood pressure's 140 on 90, she's got no protein in the urine. You've got a woman who's 35, she comes in, she's had 3 babies before, her blood pressure's 140 on 90 and she's no protein in the urine. Who's got the gestational hypertension and who's got the preeclampsia? Well, it's the 22-year-old nullet that's got the preeclampsia. And it's probably in evolution, and you have to watch her perhaps more closely than the other woman. I think we are seeing more gestational hypertension, or essential hypertension, which is being exacerbated by pregnancy, because we're seeing more obese women and we're seeing older women having babies. And so for those women, they may, their blood pressure may start to go up at around 32 weeks. Their blood pressure might be sitting at 130/80 and then up to 140/90. When do you treat them? When do you put them on an antihypertensive? You're pretty happy they're not preeclampsia, but you want to be watching them carefully because sometimes they can get superimposed PE. But you think, and then she comes in and her blood pressure's 150/100. I think 150/100 is probably a good cut-off to start treating these women.
And that's where the woman has got a normal growing baby.
She's got a normal growing baby, she's got no protein in the urine, her bloods are normal. She's got the clinical picture of someone you think, this is the Labrador, it's not the preeclampsia, but her blood pressure is getting worse, and you want to protect her cerebral vasculature. You also want to protect her from living in hospital, because every time you see her, you'll want to put her in because her blood pressure is, above 140/90. You still have to watch those women carefully, but I would pick 150/100 as my threshold for starting treatment in those women. I'd be happy to watch someone who was sitting at 140/90, 145/95 if they were consistently that, and I was happy they had either essential hypertension or gestational hypertension.
Well, thank you very much for joining us, Anne. It's been very helpful.
It's been good, thank you.
Well, our final story tonight looks at models of antenatal care. Through some combination of specialist obstetricians, GP obstetricians, GPs and midwives, there are any number of ways that antenatal care can be delivered these days. We spoke to Dr Mostyn Hamdorf and the team in Dunsborough, as well as Dr Peter Kell and his team from Peel Maternity and Family Practice, and asked them to outline the model of care they feel works best in their practice. Here's what they had to say.
About 2.5 years ago, it was just me. So for our large practice, I was the only GP obstetrician, and that was before we had a combined roster at the hospital. So while I was in town, I was available 24/7, which you had good weeks and you had bad weeks. And so that's not sustainable though. And so it was only through, and it was actually through the attending at the combined college meetings that I've been to in the past. You meet the same people at these meetings, and I was in Melbourne. I spoke to a GP obstetrician I know from Werribee in Victoria, and we were talking about different models of antenatal care, and he was telling me about his model where he employed a midwife who did the lion's share of his work. And so we had a long chat about it over a beer or two, and I came back and I raised it with the guys back here, and we discussed whether or not it'd be worth our while employing a midwife. And so from there we employed a midwife. We've had 2 or 3 different midwives over the time. They have the uncanny knack of getting pregnant on the job. But nevertheless, over that period of time, we've developed this system whereby the midwife is the universal feature of the antenatal care. Regardless of which GP obstetrician they see during the pregnancy, they always see the midwife. And with discussion amongst all of the GP obstetricians, we've structured a level of antenatal care so the midwife touches on the same things at the same time in every pregnancy.
I do just the routine sort of stuff like a blood pressure. I weigh everyone and chatting to them at the same time. Then we test urine, then I get them up onto the couch and we do an abdo-palp where we ascertain the position of the baby, make sure it's growing well, we do a fundal height measurement.
We do all the education side of it, all the antenatal education, your diet and all that sort of thing.
The midwife will, in the initial visit will actually spend probably considerably longer than I do because she'll go through all the history and all that sort of thing, and then I see them, I'll just quickly look at what's down and just double check that the history and everything is correct and talk more about previous deliveries and things that are important to me from an obstetric point of view.
I don't have time in a 15-minute slot to cover all those nitty-gritties of what do I pack for the hospital bag, how do I breastfeed, how do I know if my baby's feeding enough, and these are all the questions that matter most to the patient. And I'm worried about the Group B strep status and is the fetal hardened and what's the live... Stuff that they don't really care about. And Jody provides answers to all of those really pertinent questions to the woman, so I think it becomes more patient-centric.
The patients love the care, basically. They like it because it means that they've got a midwife, they've got the continuity of seeing the same midwife and the same doctor, and because of the team works so closely and so fluidly, if I'm called out and they don't see me that time, and they're usually not too disappointed, or that they feel that they're cared for.
They don't come away with that perception they've been rushed through an antenatal appointment. They spend considerable time with the midwife, followed up by a GP obstetrician as well. So their clinical time at an antenatal appointment would be in the order of 25 minutes, 30 minutes at any one appointment. So they do get plenty of time to discuss and raise issues.
There are certain things they might discuss with me that they might not discuss with a doctor. So, some of that I don't need to discuss with the doctor either. That just stays between the woman and myself. If it's, things like relationship issues, I may refer them to the clinical psychologist that we also have at the practice.
We tend to know what's going on at home as well. We tend to know the girls really well because we're seeing them very frequently at the end of their pregnancy. So if they're having relationship issues or problems at home, then we can deal with all that as well, the mental side of it as well as the physical as well as the obstetric side of it.
The other huge advantage that the midwife offers is that she can provide this really good mothercrafting education that me as a male GP obstetrician hasn't got a hope in Hades of offering. Similarly, she's a trained lactation consultant. She's been through training in sleep disorders at Nagala, so her service to the women both antenatally and postnatally is invaluable. And now with that new Medicare item number for midwife attendances, they can see antenatal patients in your absence.
And because we're outside the metropolitan area, we can charge the midwife Medicare rebate. So it continues to bring in practice money, and we actually keep his practice ticking over if he gets called away to deliveries or Caesars.
If she identifies a concern, she'll buzz me or come and get me and say, look, this is what I'm worried about, or I think this baby's breech, and then if I get in there and I'm not sure, I grab Mostyn and he comes in as well, and we've got three of us in there, hands-on. So I guess the way it works is we've got like layers of care, okay, from the hands-on with the midwife to then Sarah or I, and then if we feel a little bit out of our depth, we've got Pete and Mostyn to call upon, and then beyond that we either call Bunbury guys or King Edward guys, and so there's just all these layers of, once one person gets outside of their skill set, we're all very quick to recognise it and then go up the next level just to make sure that the patient's got the safest care with the least amount of fuss. So you're not getting a barrage of medical words thrown at you every antenatal visit if you're having a perfectly normal pregnancy. We just have a chat about the little things. Oh, the baby's kicking, the little things that are important to the woman, and only then go up the scale when it's indicated.
For normal low-risk pregnancies, it demedicalises the antenatal care. It the focus shifts away from the medical issues of the pregnancy and focuses more on the normal family-related matters, which are probably better looked after by a midwife than by a GP obstetrician.
And the midwife is supported. I mean, the midwife needs to be she's a supportive person and needs to be in a supported role. And the consultant obstetrician is someone that you consult for particular problems, and the GP's in the middle, sort of guiding it all. And so I think, GP-based models like this are an ideal way to go.
Well, that's all we have time for this evening. I'd like once again to thank all our guests for taking the time to talk with us. Now, don't forget that if you'd like to review this broadcast or any previous broadcasts, a delayed transmission will be available via internet web streaming next week through the Rural Health West website at www.ruralhealthwest.com.au. You can watch the programs online or download them as video or audio podcasts and listen to them at your leisure. That's if you can find some leisure. We'll be back again on the 7th of April with a broadcast on sports injuries. We look forward to your company then. From me, Gerry Gannon, and all the team, good night and thanks for being with us.